Bob, let's answer some patron emails. What do you say?
I say yes.
Anonymous long-term patron, she says, thank you, Kirk and Bob, for everything that you do. You are my favorite podcast.
Oh.
I am in a rather difficult situation. I am on the narcissistic borderline spectrum. All I feel is shame, which has made me suicidal. I have never attempted suicide, but I often talk about it as a way to end the pain of my world. Chiming in here, Bob, have you heard that sort of presentation before?
Yeah, of course.
What do they mean by it, do you think?
I think they're in pain, and suicide is sort of like an escape hatch. It's a fantasy escape hatch, and as a fantasy, it probably serves a function to relieve, the pressure of the present moment. It doesn't necessarily indicate a real risk to, act. But I take that. I want to say that really carefully. I don't know this person, and I don't want to be brazen about it. I don't know, but that's what it sounds like to me.
Yeah, that's the way that I would put it too. It's better than the way I would put it. Going on, I talked about it with my therapist, who I went to for 5 years, and we had 2 sessions a week for the last 3 years. I felt like I could talk to him about anything. I couldn't say there was any progress or that I got better, but he was extremely important to me. I loved him very much. We had a great connection despite the fact that the relationship was complicated. I often doubted, just chiming in, I don't know what she means by complicated. I don't think she goes into that.
Right.
I think it just, in all likelihood, had the commensurate, transference, countertransference, and dependency that we expect and work with when it comes to people with narcissism and borderline going on. I often doubted he wouldn't leave me, that he really cared about me, etc., which he constantly disproved, meaning, which is very common for people with borderline and narcissism, that they have this paranoia that the therapist is about to abandon them the way that they were abandoned, and that the therapist is just waiting for an excuse to abandon, which is not true. And he would constantly disprove that, which is exactly what you do with this kind of work. Yep. This therapy was more like a place where I could come twice a week to tell him everything I was feeling and thinking. The only person I could communicate without any filters and just be me. But unfortunately, I made a mistake. When my therapist was on vacation, I felt very lonely and had a lot of life triggers. So just chiming in, does this sound like something you might expect to happen with this kind of work?
Yeah, because it sounds like abandonment crisis came up.
Yeah. And the client intellectually knows, he's just on vacation, but the child within does not feel that way.
Yeah, exactly.
It's sort of like when you drop your kid off at preschool and they're crying and bloody murder that you're leaving, and there's a part of them that feels like you don't love them and you're abandoning them. And that's the way that, we're like, well, just kids, they'll figure it out, And anyway, so it sounds like the client went through that. So she was having a crisis. Mm-hmm. She says here, I bought a quote unquote a weapon. It wasn't a gun, but it was a household item that I was planning to use to kill myself. But when I got it, I put it aside and something changed in me. I wanted to live. I found that the implement was disgusting and alien. Bob, as an expert in this, because you did DBT, which specializes in this kind of moment, any thoughts on this?
Well, it sounds like acting out the fantasy sort of scratched the itch, if that's an okay way to put it, where taking the action, I can imagine what that would be like. I bet the heart rate is up when I'm actually standing at the cashier and I'm actually buying the thing, whatever the thing is, I'm like sort of taking an action here. And, but somehow it settled the crisis, just having the thing. And, it's funny, people can get pretty attached to their means. And like they can imbue special power to the object of the means. And like, let's say the means is a knife. It can become a particular knife in my house, and the other knives don't have the same association. This is the special knife or the, and so I could imagine this happening. I can imagine it's happened really frequently in the history of the humans where somebody in an abandonment crisis takes action and then, their urge to die fades.
Yeah.
Yeah.
Now, someone with abandonment trauma and they have borderline and narcissism can kill themselves.
It's not
happen.
Yes.
Yeah. This analogy just popped in my head, which I'm going to try on for size verbally, but I like it in my head. So let's see if I like it in my mouth. In that, when I had claustrophobia more intensely, I found my brand of it was that I needed to have a way out that was an option. So if I was in a car, for example, and I was in the back seat and it was a 2-door, then I would freak out or I wouldn't even get in the car. But if it was a 4-door, I was fine. This doesn't make any sense because if we're barreling down the freeway at 70 miles an hour, I would die if I bailed out of the car. But having the option completely soothed me.
Yeah.
Phobias aren't rational. The borderline concern is not rational. But when we have an out, we will never use it. To have an out means we don't need the out, if that makes it. And to not have the out means we desperately need the out.
Yeah.
It's paradoxical in that way.
Right.
So the fact that I had that door meant I no longer felt claustrophobic.
Right.
To have that implement meant she no longer needed to get the implement.
Yeah.
But to not have the out can feel terrifying and dysregulating.
Yeah.
So that's, I think, what she's describing. I want to be clear and say that, even with people with cluster B personality disorders who think about suicide, it's not always the case.
No.
What I am not hearing is a safety plan,
Right.
which might have been in place, but should have been in place.
Yeah.
But maybe there was one and she just didn't follow it or something. But
Right.
anyway.
Right. One of the things that occurs to me is the likelihood of accidental death is increased by having whatever the thing is, whatever the implement is. So it's worth getting rid of.
Yeah.
And the disgust is kind of interesting, but I think it just represents the ambivalence the person has about living, right? And maybe a critical introject, if that's an okay way to put it, some part of them that attacks them for, having a need.
Mm-hmm. Well, they say they found the implement disgusting and alien. Yeah. So I think that's one way of looking at it. Another way is that along the lines of what I said is of like, once you had it, it's like, I don't want to do this.
Right.
This is not of me.
Right.
Anyway, going on with the email. When the therapist came back, I told him about it because I had always told him everything, but something unexpected happened. He told me that I had crossed the boundaries, that I had been proactive with the action, that I was a danger to myself, and therefore he could not continue working with me.
Mm.
So I told him I would work with a psychiatrist on the suicidality issue, and hopefully still work with my therapist on, so I could...
Yeah, like sort of both.
Yeah. Regardless, basically within a week, I no longer had the therapist I work with for 5 years. Bob, what do you think about that?
Oh, well, I wonder did they have a clear understanding, like what the therapist limits were? Like, did the therapist have a clear understanding of their own limits? Because I've seen that, you've seen that where people like they panic, they freak out. They're like, oh, I'm scared that, I'm going to be responsible for this person's death. And so they want to offload the responsibility for it or the fear of it, I think it's a treatment mistake. I don't think they should do it. I think, probably want some good supervision and support because they're scared. I think being scared is pretty normal. Like, why not? I'd be scared. And I don't think it's based on what's written here. I don't know the whole story, of course, but based on what's written here, It just sounds like the therapist freaked out.
Yeah, this is complete bullshit. This is happening, I think, more and more, or at least anecdotally. When people talk about this online, sometimes they'll be like, hey, it's okay to have boundaries. And yeah, as a therapist in the past, we tended not to allow ourselves to have boundaries and to have personal safety or concern or something, right? But I think that there's a difference between having a personal boundary and being a shitty-ass therapist. Because to willingly treat someone with borderline, because it sounds like they are talking about it openly.
Yeah.
Right? But even if you're not aware as a therapist that that's what you're treating, that's an additional bullshit, because you should know the reality of human conditions, the possible psychological conditions of a human, borderline being one of them. And but I'm going to take a guess to say the therapist does understand that.
Okay.
And to terminate with a client when they present a symptom that is almost universal, or it's very close to being universal to people with borderline, that these things will happen at times, to just terminate them and abandon them, right? Like, if he, from the beginning, let's say he came to, and I've had these tough conversations. They're not easy to have.
Yeah.
I've had supervisees who have said along these lines, so just, I can't deal with that. I've tried, and I'll go through a phase where I'll say, well, let's give it a shot, and I'll supervise you very closely, and I believe in you. I will say,
yeah.
Your feelings of discomfort and terror are normal. I understand that it's unexpected, but this is what it's like to be a real therapist. This is what you signed up for, whether you knew it or not.
Yeah, right.
You don't have to ultimately do this kind of work if you ultimately find that it's not your thing. But to just run away at the first sign of discomfort, I don't recommend that. So I'm here to help, and so I'll go through 6 to 12 months with them, and half of our supervision meetings are talking about this one particular case, and 9 times out of 10 they'll emerge on the other side as with a comfort level or a roadmap, and they are set to treat more people with cluster B, or all personality disorders for that matter. But every once in a while, there's someone that will say ultimately, no, I hate to disappoint you, Kirk. I'm sorry I'm letting you down, because, it is letting me down, because yeah. I want more clinicians out there that understand how to actually help these people. And I also have high hopes because it is very rewarding work. You and I chose to work with these folks. We not only accept and work with these folks, but we actually invite, we seek these people out, because it is very hard work. It is very stressful, but it's very rewarding, because we got into this to help people. Yeah. And these people need a lot of help and benefit from specialized, anyway.
And helping somebody is fantastic.
Yeah. So when I have a clinician that says that they can't do it, then I say, okay, well, then you're going to have to, in an ethical way, have a robust screening system that will catch people that might or might not actually have cluster B personality, and you would have to err on the side of caution and have a lot of false positives and refer out a lot of people before they even set foot in your office. Or maybe you have a first session, but you tell everyone that there's a 50% chance that after talking with you for one session that you will find that their issues are better served with another clinician. That's okay. But you've got to be responsible with that, because you can't get into the transference with someone with borderline after 5 years of 2 sessions a week and just say, oh, this is too much for me, because they had a typical presentation of borderline, which is to have some mild suicidal thoughts. And, some people say it wasn't mild, she got a weapon, a means. And if I were to do an assessment, certainly that is alarming. It's not just mild ideation, but intent is important to assess. People can have a plan, they can have a means, but intent is something that has to be included in there. For example, you can have intent but not have the means or a plan.
Yeah.
And that's a different scenario.
Right.
It's actually more dangerous because people can within a few hours get the means and the plan. But some people will have ideation, plan, and means for their entire life and never have spikes in intent to kill themselves and never attempt. So anyway, I have a whole system of assessment that's similar to other models. But the point is that for a client to exhibit a very normal part of the borderline condition, especially when there's a vacation, and the way she's framing it is not to say that she's blaming. Now, there's a possibility that there was more to this story, and he terminated because she did a lot more than that. Who knows?
Yeah, we don't know.
But in terms of the way it's described, I'm not surprised because I've heard this before.
Yeah,
that there are some therapists, they just have this policy of just like, I don't work with suicidal clients. And it's just like, okay, that's weird because that's like being a cancer doctor and not working with people that have cancer. People come to therapy because they have problems, suicide being one of them, suicidal thoughts being one of them. It's not like they are, I don't know, I'm trying to think of like something that's ancillary to psychology, like they are involved, like say they're involved in the mob, it's like Sopranos. That's not inherent to psychology. It's not inherent to the treatments or the assessments or to the common conditions that we face. And as a therapist, you might not want to deal with the stress of having a client that's in the mob because you don't know what that would entail.
Yeah.
Maybe they would tell you things that would cause you to worry about having to report, or if you did, would they whack you, as they say in the movies,
the parlance, right?
Yeah, or you just don't know. Because when you signed up to be a therapist, I think it's reasonable to say I wasn't expecting this. To sign up to be a therapist and to be surprised or overwhelmed or shocked by a client that has just suicidal thoughts. But even if there was an attempt, it's stressful. As you were saying, it's stressful. It's scary. It's hard. But who said being a therapist was easy? Did anyone say being a therapist was easy? Who told you that at the beginning? I don't imagine anyone said that being a therapist was going to be a walk in the park.
I never heard that.
There's so many other jobs that you could do that don't involve this stuff. Work in IT, work at Amazon, work in the restaurant industry, work in the medical industry to some extent, because you could narrow your focus to like, I don't know, podiatry or something, and you don't have to deal with cancer and death as often. There's options.
Do you think podiatry might be easy? It might be. I don't know.
I'm just going to take a guess and say they don't deal with not
a whole lot of foot crisis.
Well, of death and of suicide and whatever,
right.
That kind of just
life-threatening.
Right. A lot of, sprained ankles and broken bones and tendon tears and,
fallen arches,
foot pain and arches. Yeah. And corns. What do they call those?
Corns,
Bunions. Yeah. Plantar
fasciitis.
Yeah.
I had that.
I'm just saying there's a lot of other jobs in the world, and why did you sign up? Or just don't be a therapist.
Don't be a therapist.
Yeah. So I don't know. And the fact that it came out of the blue. If they had talked about this, this is about informed consent.
Yeah.
I wouldn't agree with this.
I would not either.
Because how would a client know what the future would hold? I mean, we should know as therapists that it could happen.
Yeah.
But it sounds like it came out of the blue, and that's an informed consent issue.
Yeah.
Actually,
there's a liability for treatment abandonment.
Right.
Unless, there's ways around it, but the whole thing is an abandonment, which is, of course, why the person is in fucking therapy to begin with.
Right.
Because they have abandonment trauma, and maybe this is a way in which that trauma is being enacted,
right?
And it has to be survived.
Yeah, and so not only survived, but corrected for by the
Right.
therapist,
Right.
for them to say, unless something really weird happens, like you threaten to kill me or something,
Right.
I will never leave you.
Right.
And because you have emotions
Right.
and impulses, but going on. Now I feel like I've lost one of my closest people. It also reinforces my feelings that everyone is rejecting me, abandoning me, and that I'm shit, and that I'm disgusting to him, that he was just waiting and looking for a reason to get rid of me, etc. And I don't really know how to go on because I can't imagine investing in another therapy process because at the moment it feels impossible to open up and trust someone, knowing that the end could be like this. I am, of course, grateful to him for the time we spent together and the conversations we had, but I'm also unspeakably angry that despite the fact that he promised he would not leave me, that he told me I was important to him, that he had many emotions and feelings for me, that he was happy to know me, despite all of this, he threw me out. Of course, I understand that I may have crossed the line or that he fears for my life. He also said that apparently therapy doesn't work if I take that step. Do therapists really have to abandon their suicidal clients? Is it unethical to leave your clients? Bob, what do you think?
We think we covered that already. It is unethical.
Yeah.
Yeah.
Is the ethical police going to put him in prison? No. If you made a report, might there be a response from the licensing board? Maybe. But I could see if he were to respond in the initial investigation in a way that demonstrated a viable justification for having terminated with you. And if he terminated with you well, like he gave you a number of referrals or something, I could see the licensing board saying, no, everything's on the up and up.
Right.
Because there's a lot of wiggle room when it comes to this sort of thing. There might be something that I personally would think to be really bad therapy, and clearly not the standard of care in my book.
Right.
But the licensing board has a very, very high bar for what they consider to be actionable.
Well said.
Things like having sex with your client, that kind of stuff, which is actually a very frequent thing that they take action on. So there's that, and it's unfortunate. And like I said, it's something that I've heard before. It's something I've heard people having conversations about people with borderline where they're like, there's all sorts of justifications for terminating with people with borderline because of stigma and not understanding and labeling people as being a problem. It's a problem. But anyway, let's take a break. We get back. More emails. What do you say?
Yeah.
All right, we're back from the break. Let's do an OPP. These people became patrons in the early part of 2023, so about 2 years ago. So at the annual mug level, we have Catherine and Rachel from God knows where. And at the annual highest tier patron, we have Sandra from Calgary, Alberta. Thank you for being a highest tier and annual patron. And then we have just a regular monthly highest tier patron, Raua from Lynn, Massachusetts. I'm sure I'm pronouncing that name wrong. Raua, I'm guessing, from Lynn, Massachusetts. So all those people, thank you so much for being a patron for the last almost 2 years, and also for being such a high, tier patron. It's really, really nice of you. I wouldn't be able to. We wouldn't be able to do any of this if it weren't for you. Seriously. Okay, next email. Long-term patron Carter from Rhode Island. He says, Could you and Bob please discuss splitting, and if possible, ways to help oneself when in the midst of an episode of splitting? I was diagnosed with borderline about a year ago, and I find the hardest symptom to cope with is when I'm splitting. Love you both dearly, Carter from Rhode Island. Bob, what do you think?
Well, I wonder how they define the term, like what they mean by it.
What do you think?
Well, I think splitting is when I have inside me a tendency or a vulnerability to believing that an object, another person, say a therapist, whatever, it doesn't matter, is either good or bad. right? And then, of course, that has a lot to do with how I view myself, right? Am I a lovable person, or am I, kind of a hateable piece of shit, right? So when I think about splitting, I think that that's what it is.
Mm-hmm. So it could involve black and white thinking or idealization, devaluation
yeah.
of oneself or other people.
Yep.
So ways to help oneself in the midst.
Well, I mean, you're already off the bat. You're saying that you find yourself doing it. That's fantastic.
Yeah.
Because a lot of times when we're doing that sort of thing, we believe what we think.
Yeah.
Right. So this is fantastic, Carter, that you're seeing, recognizing. And you know what the fucking thing is having that kind of 10,000 foot view doesn't fucking help much. It's like, it doesn't make my paranoia go down. It doesn't make my fear go down. It doesn't really, because like we're made to believe, especially when we have an intensity of emotion, we're made to believe what we think or what we're telling ourselves. So you're in the Matrix. You're in the Matrix.
What do you mean?
Oh, like that film, The Matrix,
I know. But...
Yeah. Oh, in The Matrix, if you die in the Matrix, you die in real life. That's how it feels, right? It feels like, oh, this is like the agent. This is an agent I'm facing, as an enemy. It's my metaphor's breaking down. So it feels real, and you're recognizing that it isn't real, but it's still compelling. Self-soothing is a good choice. I wonder if...
DBT must have had a technique along these lines, right?
Oh, yeah. Let's see. So DBT is going to talk about emotion regulation, which is like things that I do to help settle my emotions down. I can't believe this. I haven't been teaching DBT for not that long, and I actually can't remember DBT very well.
That's funny.
And distress tolerance, which is when life is shitty, what to do, how to get through it. And you already have a good chunk of that going because you have a level of acceptance that this is indeed something your brain does. And even though you recognize it, it's still disconcerting. I think, though, what you're wanting is a way to eliminate it. I don't think we get that.
Yeah. Yeah. You talked about the 10,000 foot view, and that's really the only thing that or at least I think that's the first thing that I do when I work with people like this is well, I guess there's two things. One is I frame it as a question mark. Because
nice.
At least the metaphor, the visualization is simple.
Yep.
I ask people to literally imagine a question mark, to focus on a question mark, because in the moment it feels so certain. And
that's fantastic.
If you just have a question mark there, it could be true, the devaluation, but there's a question mark. And then the second thing is to try not to think so much about it, which sucks. And this applies to everyone. This applies to me, that when I'm upset, I just think about...
Oh, yeah, you do this all the time.
What?
This thing that you're about to describe.
Yeah. I find I'm at my best. It's hard in the moment when it's intense, but all of us will have moments of hurt and anger at our partners. And in those moods, for all of us, when you remember those modes and those moods and those states that we're in, we can't relate to, and especially if you really remember, or you are a journaler like I am and you read what you're writing,
oh, right,
you can see that it's like another person.
Right.
And it's really hard to see that you're another person in that moment. And one of the things that experience has given me the wisdom of is that when I'm in that state, I remember, because I emphasize it enough and I drill it into my head enough, that when I'm in that state, I have a vague sense that I am in a state, and that at some point, regardless of what I do, I because it feels so important to solve the problem, to right the wrong, or to communicate the thing, or to see eye to eye. And I, in the moment, will have, 20% of me that will know that I can do nothing and everything will be okay. Or it won't, at the very least, feel even close to the emergency that it feels right now. Yeah. And so if I just have a question mark and I just give it some time, and just accept that the next 24 or 48 hours is going to be a little ruminaty, if you will. But just don't get uptight and don't do anything. Maybe you're in a bad mood towards your partner a little bit, but that's the best you can do, because if you try to change it, you'll open your pie hole and you'll say stupid shit. And then it'll be worse. And so now I'm not saying that's the only way to be. Of course, there are moments when you can have the conversation in the moment, but there are so many times that I wish I would have done this. And there are times when I do it that I think, oh, I'm so glad that I did that. And you could think of it as like a physiological experience where, like a panic attack or something, it's a wave that comes or a storm that comes, but eventually it goes away.
That's a good way to think about it.
It's not here to stay.
Right.
And the thing that I will tell clients is like, it feels like an emergency, but here are the criteria for a legitimate emergency, like someone is bleeding out, for example, or things along those lines, and which are, of course, never the case in these emotional, conflictual moments. And so unless there's an emergency, you might be better off just telling yourself, I just need to not take action until I get perspective, which I very well will have, especially if I do nothing, because if I do nothing, I won't make it worse and I won't poke the bear. And so in a couple of days, in all likelihood, my physiology will be regulated a little bit better and I'll be able to think straight. And if I still need to do something, I will.
Yeah.
I promise myself.
Yeah.
Because in the moment you might feel like, well, if I don't do something now, maybe I'll never do something.
Right.
And it's like, okay, I promise myself that if next Monday I still feel compelled to take action, I promise myself I will, but I'm just not going to do it now.
Right.
Now, maybe you will. Maybe on Monday, after you think about it, you go to therapy, you're like, maybe I will. But you're going to do it better.
Yeah.
You're going to have a better attitude, a more rational,
probably more successful approach.
Yeah. So that's, I think, the best we can do.
That's good advice. I like it.
Let's take a break and another email when we get back. What do you say?
Yep.
All right, we're back from the break. This email is from an anonymous patron from Chicago. She says, "Hi, Kirk and Bob. I have borderline, and I have been working with my current therapist for almost 2 years. We have great rapport, partly because he also has borderline and can relate to my experiences on a different level.
Wow.
Recently, he recommended that I see an additional therapist to address my eating disorder, which is out of his scope." Bob, what do you think about that so far?
I like it. Yeah, like he's operating in his own lane and recognizing where he has a limitation or an area of expertise that isn't his and suggesting something useful to you.
Yeah. How is this different from the suicide thing?
Well, he's not abandoning therapy. He's like, hey, you should do this in addition. Keep coming here. Go there too.
Yeah.
Yeah.
Yeah. And eating disorders are very complicated and involve a different, often a different mode of therapy. With the clients that I've worked, because I used to specialize in eating disorders, and the kind of work that it requires for most people, if they have a serious eating disorder and they're still symptomatic, is it has a lot of addictions style to it, and it's intermixed with trauma treatment as well.
Yeah.
But there's a fair amount of that kind of abstinence talk and monitoring, and myself as a therapist, I'll be asked by the client to hold them to a standard or to a hope or to a goal. And it's a weird mode because it's one of the few modes of therapy where the client might slip into 3 months of at least what's coming forward for them as someone that doesn't want to work on it, and they either hide the eating disorder behaviors from me, or they tell me that it's happening and they don't want to face it. they just want me to leave them alone. And as a therapist, I'm a collaborative person, and so I might think that there's a problem there, and I might say so, but I'm not going to get up in arms about it. But when it comes to eating disorders, the standard of care is that you can't just let that go because they could die. And they're asking you in a previous moment that you please help them, or you're being tasked by family members to do that. And it's, generally speaking, and there's different models to this, and I just found this to be true, that if I operated like my normal mode, I wouldn't be the best therapist for someone with an eating disorder, especially if they're in the midst of their symptoms. And so for a therapist to say, this is out of my scope, and or I don't want to muddy the waters of the work that we're doing with your borderline because it already is so complicated and there already is so much transference and countertransference. I don't want to add this to it because it could ruin treatment.
To be at odds with.
Yeah, because it would create this adversarial relationship, and I feel for myself, I feel confident navigating those waters, but it was different. It was hard anyway. So I could see that going on.
Yeah.
And another thing I'll say is that there are a lot of new organizations that I see, at least in Seattle, that specialize in eating disorders, and they use the standard of care and the often recommended methods like group therapy and day treatment, and much more akin to addictions treatment, where there's modules and general emotional regulation skills and trigger skills and that whole model, and that requires sometimes all the things that you would get in addictions treatment, where you have group therapy, you have a sponsor, you have other people that you're hanging out with that are also trying to avoid being triggered, because if you just hang out with your friends, there might be triggering that occurs when you're in the fragile first stages of recovery. And so you need to hang out with in a similar way that if you are struggling with alcohol addiction, you want to hang out with other people in recovery because they are dedicated to sobriety like you are. And so, there's just a lot of that.
Yeah.
And anyway, going on. Since working with this other therapist, so anonymous patient from Chicago, since working with this other therapist with the
eating disorder,
I have noticed some attachment struggles coming up. I tend to regress, and in my regression, I have a response of rejecting my eating disorder's attempts to comfort me and only want my primary therapist. I tend to regress, and in my regression with this new therapist, I have a response of rejecting my eating disorder's attempts to comfort me. Do you understand what that means?
I think they say they don't want to do, I think it says they don't want to do the eating disorder behavior because it, even though they see it as an attempt to comfort themselves, they reject that form of, it's not really coping, it's dysfunctional, but nonetheless, that form of, that action, I don't know, but I wonder if it's like, I'm afraid I'm going to lose my therapist if I engage with the eating disorder person or the eating disorder stuff. It's like, if I do this, then I'll lose you. You won't want me no more. I wonder.
And paradoxically, they're saying that because of that worry of losing their first therapist, they're clamping down on their eating disorder impulses and not engaging in their eating disorder impulses, which might be a regression on the eating disorder, because not being behavioral with your eating disorder doesn't mean that you've cured your eating disorder.
Yeah.
Anyway, going on.
Right.
This, along with other experiences, makes me worry about the fit with my eating disorder therapist. Am I overly attached to my primary therapist? I'd love to hear your thoughts. Bob, what do you think?
Well, we don't know. Overly attached, I'm not sure what that term means. I doubt it, though. I don't think people get overly attached. I think they just deal with what comes up in them, and that's what comes up, like a degree of abandonment fear. I it's hard. I don't know if your eating disorder therapist is a bad match. You have reason to think that they're not a bad match, in that you have this wonderful self-awareness of this thing that you're doing to avoid your abandonment fear, by just ignoring eating disorder and all that goes with it. Just like, oh, I don't have that. That's pushed off I don't need that person. So now I can just go back to individual therapy. Seems like the direction that your mind is taking you. So how do you assess whether or not your eating disorder therapist is a bad fit? I would talk to them about it. Are we a bad fit? Because I noticed that in our work together, here's what comes up for me. You could experiment with another eating disorder therapist, though. Grain of salt on that. While you should turn over all the stones, jumping ship isn't necessarily the best thing to do, because maybe that just sets you back, and you're going to be in the same boat 3 months from now.
Yeah, and the way that she's framing it, it has to do with her, not the therapist. Necessarily.
Yeah. Nicely put. Yeah. So there's reason to think that's what's going on, and you're just probably scared to death.
Right.
So maybe talking to your personal therapist about it. Am I going to lose you if?
Yeah. And eating disorder treatment is hard.
Oh, fuck yeah.
So you're doing two hard things.
Yeah.
Borderline treatment and eating disorder treatment.
Right.
Both involve trauma. Both involve a lot of shame and a lot of difficulty and a lot of internal impulses. And it's hard. So is there likely to be some convulsions of comfort? Yeah, that's what I hear. But yeah, just do what Bob always says, talk about it with both of them.
Yeah.
One more email. I thought I would get through all the borderline related emails
all right.
in one episode. Anonymous patron, she says, how can you distinguish between narcissistic personality disorder and borderline personality disorder in a partner who exhibits controlling and abusive behaviors?
Oh.
If someone in your life rushed into the relationship in the beginning and then became more and more controlling and abusive over time, how can you tell if they have borderline or narcissism? For example, they control who their partner can hang out with. For example, no friends of the opposite sex. They prohibit their partner from going to parties without them or at all. They stalk their partner to see what they're up to and if they're cheating. They frequently have angry outbursts that sometimes include physical violence towards their partner, and even stalk their partner's exes and threaten them to back off. From what I understand, both disorders can involve these behaviors, so how can one differentiate between them in such situations? Bob, what do you think?
Who cares? Who cares? Whatever you want to, if this is the behavior of a partner, then you got to get fucking out of that relationship, because it doesn't matter what you call it, it's still abusive. So who cares?
Yeah. Yeah. The other thing is that hearing those very quintessential and concerning behaviors of abuse and control and coercion, I'm not hearing necessarily narcissism or borderline.
Yeah, it might not be any of that. It might just be sort of a general asshole, or maybe they're antisocial. Who knows?
Yeah, that wouldn't be my short list of assessment endeavors. If I were to hear this about the person, and then that abusive person came into my office, my priorities would be on the safety and the harming that this person is committing, and the perpetration, and then secondarily, after I establish safety and lack of harm, I would be assessing schemas and attachment disruption. We might go down a road of assessing for narcissism and or borderline, but we might not.
Yeah.
I'm guessing, anonymous patron, that you're getting this from online discussions, because I don't think I talk along these lines. Certainly people with borderline. So the profile that you lay out, anonymous patron, might that person have borderline or narcissism? Yeah.
They might.
Absolutely. People with borderline and people with narcissism will do this more often than not. Well, I guess either. But I would, in my anecdotal experience, it's more likely borderline than narcissism. if it's a man that's doing this, people tend to assume it's narcissism, and they can't imagine a man having borderline.
Oh, yeah.
But with borderline, you are very afraid of abandonment. You see abandonment around every corner, and if you are a man, you might have absorbed toxic masculinity, or you might have seen it in your family growing up, and you will have a greater likelihood of resorting to abuse and control and violence. Women, people with borderline and that are abusive, will do this absolutely as well. And people with narcissism, they tend to abandon when things get bad. They tend to run, like avoidant attachment. They can be abusive for sure, especially if they're what I would consider to be someone that's that could be characterized as being somewhat of a mix between narcissism and borderline, which there are people like that. Because the central feature to preoccupied attachment and borderline personality is that you're terrified of abandonment, and you neurologically are hyper vigilant and active about gaming the system to retain attachment security.
Right.
You don't just wait to be abandoned and then react. You are proactive and assuming that abandonment is happening, and it compels you to feel hurt and angry, and it compels behavior to make sure that the current abandonment that's happening doesn't happen, which can result in classic abuse like what we're hearing, but it can also result in non-classic abuse. Also, it can result in just regular preoccupied hypervigilance and concerning, bothersome behavior. I guess it's never a pleasant thing to have someone that is assuming you're abandoning them, and then they get hurt about it, and you've done nothing, and they're angry at you. You know what I mean? So, but anyway, that's that answer to that question.
Yeah.
Well, let's adjourn there.
Hey, we did it.
Tune in next time when we answer emails that are in all likelihood not related to borderline. And please take care of yourself, because
you deserve it.